All right, everybody come on in. We're going to start. We really want to make sure we stay on time so that we can get the whole day delivered to you. Now you get kind of a special treat. You get all three of us at the same time doing something I hope that you'll find interesting and a little bit unusual. I'll describe that a little further as we go along. This is a talk that focuses on attention deficit disorder, especially in adults. Faculty disclosure. Just point out how badly I'm carrying up the rear on these. You notice I've got one little liner in the bottom. Here's our general disclosure. Here are our learning objectives. Okay, so this talk has a couple of disclaimers. The first one is that I have no adult children. Well, I guess that's the only disclaimer. I think we had a couple other ones that we lost. So we want to act out for you a case that really highlights some of the challenges around adult ADHD. And given that I'm not an expert in ADHD, I get to play somebody different. So I'm going to play somebody who does, in fact, have adult children when he's wearing this hat, and he back to Dr. Raison when the hat goes off. So here we go. Hey, guys, good to see you.
Hi, Chuck.
How are you? Thank you. You know, I appreciate it. There's so few psychiatrists that are willing to talk about research with a gastroenterologist like myself that I really appreciate you going down to the guts of things. So, buddy. Everything going okay with you guys?
Yeah. How about you?
Well, you know, the research has been okay, but, you know, and I know I've talked to you guys about this a little bit before, but I'm just, you know, I'm worried about my son, Matt. He's just really been having a hard time.
What's going on?
Well, actually, if we can set aside for a minute and talk about that, because you guys are psychiatrists and I can maybe pick your brains. You know, I mean, Matt is such a good kid, and he was, you know, he was normal until he went to college. But, you know, almost immediately in that first semester, once we dropped him off and left, he really began to have struggles. He had just horrible trouble with his classes. He was just, you know, his grades weren't good. He just had a hard time staying with it. He dropped out of some classes. And, you know, poor kid, he started getting so depressed and anxious that we really started worrying about him. And then, you know, there's a little bit of alcoholism that runs down my side of the family. And, you know, college being college, he started binge drinking. And it really began to get out of control. I mean, by the time his freshman year was over, he was really in bad shape. He came home for the summer, did much better, still drinking too much, we thought. But, man, he went back to school his sophomore year, and he just collapsed. And the drinking really got out of control. And so we had to pull him out of college. Thank God he had some insight into the fact that he had problems. We put him into an inpatient substance abuse program. He managed to get a hold of the drinking, and they started him on SSRI, you know, antidepressant, and it really helped him. I mean, it's amazing. It really made a difference with the depression and anxiety. And we were hopeful that everything had been solved, you know. And once again, winter semester, we put him back in school. And he didn't go down to tubes again in terms of depression and anxiety. He stayed sober. But man, the anxiety did start creeping back, and the same problems. He was having all these trouble with classes. He kept telling us he couldn't concentrate, kept telling us that he couldn't keep it together. So it's just horrible, you know. So he's doing better, but I'm really worried about him, you know, because really the anxiety seems to be getting worse again.
Chuck, you're describing many things here. You're describing anxiety and depression. You're describing substance abuse. But it seems like he was also having problems with schoolwork.
Yes, absolutely.
Maybe something that interfered with with his concentration. Has he had any of those issues earlier?
Well, you know, it's interesting you say that. You know, when Matt was a kid, we were told by a couple of teachers that he might have attention deficit disorder, you know, this ADHD business, right? And, you know, especially my wife just thought it was a fad diagnosis. She actually got irritated the day. She thought he was just sort of being creative. And I mean, I hate to throw her under the bus, but she's not here. I'm going to throw her under the bus, especially since she doesn't really exist, you know. So, I mean, but I was guilty too. I mean, we sort of thought it was a fad diagnosis. You know, I mean, it's all over the place nowadays. It's, you know, promoted by pharma. You know, you know, he did okay. I mean, you know, he was definitely a squirmy little kid. He was hyperactive, but he did okay in school. And, you know, given that really he's our only child, he started having, to be honest, I think he started having more trouble toward the end of junior high. So when he went into college, my wife quit working. and really dedicated herself to him. She'd sit down and help him with his homework every day and all this sort of stuff. So, I don't know, it's an interesting question of, maybe in retrospect, it didn't just all start in college.
The reason I'm asking about this, Chuck, is that some of the cardinal symptoms of ADHD are nonspecific. So when it comes to inattentiveness, when it comes to cognitive and executive problems, anxiety disorders can contribute to having difficulties in these areas. Mood disorders, and you mentioned that both of those can contribute to difficulties in these areas, as well as substance abuse. But in addition to that, I've known Matt for a long time, so I think we can safely exclude any risk of autistic spectrum disorders. They can be also manifest in a very similar way. I think we can also safely exclude schizophrenia, which interestingly enough starts with cognitive problems. So this is not the case in Matt's scenario, but just so you're aware of it, cognitive deterioration in schizophrenia starts 10 years before the first psychotic episode. So by the time schizophrenia manifests itself, most of the cognitive deterioration has taken place. That is why it's so hard to get it back. In neuropsychiatric conditions in general, once you lose territory, gaining it back is pretty hard. And to my awareness, Matt has never been traumatized, right? Because PTSD can be also associated. While we cannot be, with the information we have now, certain that Matt has ADHD because there are other factors, it's definitely something that I think bears a little bit more examination.
Yeah.
Your wife mentioned something about ADHD being a fad.
Absolutely. I mean, isn't it the case that it's like way overdiagnosed in the United States, that it's mostly here in the U.S., it's pushed on TV ads, it just, these things come and go. It's like country western music was really popular after Urban Cowboy.
So I would say that internet diagnosis of ADHD has increased, but clinical diagnosis of ADHD has actually not. So if you use strict ADHD criteria to make the diagnosis, nothing has changed in 30 years.
Really?
No, diagnostic rates are still the same. So if we use strict clinical criteria, there really is not an increase in ADHD diagnosis.
But it's mostly in America, right? I mean,
yes, except that it's not. Actually, ADHD is based on the large World Health Organization sponsored study. It's actually more prevalent in South America than in Africa than in the United States.
Really?
Yeah, it's not very well known, but that is accurate. So it can be seen at different geographic locales. And no, we're not the world leader in ADHD. I mentioned that there are strict criteria, and I know you know most of this stuff, but just to remind you, there are a group of symptoms that are manifest as part of inattentiveness, and they include being forgetful, being scattered, losing things, forgetting things, daydreaming during the class, being disorganized, can't find homework. All these symptoms can represent inattentiveness in ADHD. And in order for that to fit criteria, we mentioned the importance of criteria, one needs to have 6 out of 9 of these symptoms. In adults, it's sufficient to have 5. So since Matt is an adult now, whoever is examining him would need to look at 5 of these symptoms. In addition to that, there are symptoms of hyperactivity and impulsivity. And they would, a lot of folks who have ADHD are viewed by their peers as being rude. And this is not a matter of rudeness, it's a matter of impulsivity. They will often interrupt conversations. They will talk excessively. People avoid having conversations with these folks because they can talk so much. In school, they're often the ones who cannot wait their turn and will blurt out the answers during the class. Sometimes they get so fidgety and restless, they have to get out of the seat and leave class, and I don't know if Matt has had any of those issues.
A little bit when he was younger.
Right? But again, in order to meet the criteria for younger children, so up to age 17, it's enough to have 6 out of 9. For Matt, it would be 5 out of 9 of these symptoms. And it's good to keep in mind that DSM-5 has updated some of these criteria. So there are adult behaviors, such as forgetting to pay bills. I've actually had a patient who forgot to pick up kids after the activity in school. Bad marital argument afterwards, right? Yeah. So these things can happen. It's both you and your wife had to wonder, is this ADHD based on when it appeared? I heard you say that some of these symptoms were actually present, except Matt's a very bright kid.
He's bright, which is lucky.
And there's good home life and structure, and therefore it may not have been manifest. But very often ADHD that starts in childhood is propagated into adulthood. The problem is that our colleagues don't very often think about ADHD in adults. So although the prevalence of adult ADHD is somewhere between 3 and 5%, so there are a lot of adults who have ADHD, only about 1 in 10 have received treatment over the course of last year. Also, comorbidities. Matt has issues with substance abuse. Mood disorders, anxiety disorders are also frequent comorbidities, and that is most often the reason they will seek mental health help. Approximately 15%, based on some studies of the children who are diagnosed in childhood, will retain these symptoms in adulthood. So we have come to believe that ADHD has to start in childhood. As a matter of fact, recent criteria have updated the limit. The limit used to had to be present before age 7, and it's now before age 11. So although manifestations are slightly different in adulthood, in that it interferes with work, one doesn't get paperwork turned in time, one can't sit still in business meetings. Somebody I'm seeing actually is on the verge of panic attacks because he can't get out of business meeting. And the reason he can't get out of business meeting is because he is chairing them. and he is afraid that his ADHD will become obvious to everybody. And excessive spending can also be manifestation. But these are the studies that Chuck just blew my mind. All of these studies were published within last 3 years. They are the true longitudinal studies, monitoring the same group of patients over the course of 15, 20 years. And here's what they found. In individuals who met the criteria for ADHD in adulthood, between 65 and 90% never had ADHD symptoms in childhood.
Really?
So I hate to say it, but your wife actually may have been right. It could have been that Matt has had some ADHD symptoms in his childhood, not enough to interfere with his functioning. And it could be that it has become a manifest later on. So based on this data, there's a big discussion about possibly changing diagnostic criteria. But this is new. This is really just a breaking story. Yet, if it does appear in childhood, most of the criteria for that would perpetuate ADHD are not present in Matt's scenario. So children who have hard time with social communication are the ones who are most likely to have ADHD persist into adulthood. Children who have lower IQ are the ones who are most likely to have ADHD persist later on. Patients who have difficulty with pragmatic language, they are the ones who are likely, like break the leg, why are you being mean to somebody? They're the ones who are likely to have ADHD symptoms later on. So there are some scenarios, and none of them really apply to Matt. Something else that confounds the scenario, we think about ADHD as being associated with inattentiveness, which is very nonspecific symptom. But actually, number one symptom in frequency in adulthood is executive dysfunction. So it's not explicitly stated in the criteria, but that is number one and the most reliable manifestation of ADHD.
And that's like having, what is that, like having trouble making decisions?
So making decisions, prioritizing. I have 4 hours in the morning. Our initial agenda, maybe there may be 5 or 6 tasks that we need to accomplish during those 4 hours. With 1 and 2, we're running late. We now need to decide, what is the absolutely necessary thing we need to accomplish during the morning and what it is that we can
That's
postpone.
Matt. Yeah,
So
Matt,
it is
that's it right
monitoring
there.
your progress
Yeah.
in time and reprioritizing, staying organized.
That's what he is
right?
just not able to do very well.
Yeah, so that is number one manifestation of ADHD in adulthood. And you mentioned comorbidities, so some of the things that Matt is displaying could actually be comorbidities of ADHD. As a matter of fact, drug dependence, I think I've heard questions someplace, what is the most frequent comorbidity? Drug dependence actually is the most frequent comorbidity of ADHD, followed by mood disorders. Bipolar disorder is very frequent. Depression and anxiety disorders are quite common in this population. So there's always chicken and egg question. And how often is ADHD comorbid with other conditions? Well, really not that often. So in terms of ADHD population, only about 1 in 10 will have comorbidity. But on the other hand, amongst mood disorders and substance abuse, ADHD is a very common diagnosis. So it's not symmetrical. And in terms of priority, when it comes to mood disorders, ADHD starts first. So it's first ADHD, then mood disorders. In terms of substance abuse, almost invariably, 99% of the time, ADHD will start before substance abuse. When it comes to anxiety, it's more like 50-50 proposition. And it's interesting that Matt has exhibited anxiety from early on and has it now. So what is the problem with ADHD and why I would urge you to see one of our colleagues? Because if youngsters do not have ADHD diagnosed, they are much less likely to complete college. They're much more likely to be unemployed. They're more likely to have motor vehicle accidents. And sadly enough, problem drinking. Yeah. I think that Matt needs to get the right kind of help. And frankly, there are some dire consequences. You guys have been lucky to ADHD. This is a study that was done in Denmark. Nordic countries keep impeccable medical records. So this comes from a pool of individuals that is 1.9 million. Virtually everybody in the country was represented in this study. Many of these individuals have ADHD, and here is what they found. Mortality rate ratio in ADHD in adults, so this is older than 18, was increased by 400%.
Wow.
Fourfold likelihood that one will die above age 18 if one has ADHD. I don't know if you're surprised, but it affects girls and women more than men.
Really? You mean the risk of death?
The mortality
and I assume
ratio.
that's just because boys are so crazy and dumb that they're likely
Absolutely.
to kill themselves.
Absolutely. Absolutely. They're more likely to, drive cars with their eyes closed, even if they don't have ADHD.
I wouldn't know about that.
Yeah, of course. Or ride their skates down the stairs. So young men are likely to do foolish things much more than women. But on the other hand, women who have ADHD, there's big discrepancy in mortality ratio compared to the ones who do not have ADHD.
Okay, so clearly, I'd already sort of been thinking about this. How can we figure out whether now as kind of a young adult, whether Matt has ADHD? Is there a way to do that?
Well, there actually is an adult ADHD self-report scale. Mm-hmm. And to use this instrument, it's literally minutes. There are only 6 questions, and they've made their job really easy because the boxes that count are shaded yellow.
I see.
So if one has 4 positive answers that are in the yellow shaded area, that means that there's a high suspicion of ADHD. After one establishes the risk, there are additional 12 questions that can provide more specific information about ADHD manifestations. So again, very, very easy to use, available. One can download it in case a professional you see doesn't have it. They can download it for free from internet.
Okay. So, got to pretend like 6 months have passed. You see, I've taken the hat off, so I'm back to being a doctor. All right. Gentlemen.
Chuck.
Good to see you.
How are you doing, buddy?
I'm okay. Hey, listen, thank you. That idea of actually looking to see whether or not brain waves influence bathroom habits was awesome. Thank
Really?
you. Oh yeah, we're going to try to get it into JAMA. I mean, thank you. You guys are going to be famous gut psychiatrists. So
How about the brain gut studies? How are those going?
they're going okay.
Okay.
Yeah, they're going okay. So anyway, thank you. Listen, also got to thank you guys. You were so helpful the last time we got together about Matt. So before we jump into, how to look at sphincter tone versus brain tone, let me give you a little update.
You gastroenterologist.
Well, all professions go into what they're interested in, right? So, after I talked to you guys, we took Matt to see his family doc. And, unfortunately, the guy said, he sort of had the idea that we'd had, that it was just sort of a made-up diagnosis. So he wouldn't agree to do any kind of treatment. So we were a little bit too passive, actually, and we let it go for a little bit. But, Matt's back in college, and he's same thing. He's just struggling with classes, complaining about trouble. He'd actually read about it after I talked about it and began to increasingly sort of recognize himself in it, and would come to us and say, man, this executive dysfunction thing really stayed with me. And I think it really hit him. So finally, we took him to see a child psychiatrist who sees a lot of adult patients. He did a full workup and said, yes, based on current symptoms and what appears, Matt's past, that he does meet criteria for adult ADHD. So they started him on some kind of extended release methylphenidate and kept the SSRI on board. And within a couple of weeks, man, shocking difference. I mean, dag nabbit. All of a sudden he was able to organize, complete his school assignments. His grades began to come up, and you could see within a few weeks that as he began to get traction in those areas, his anxiety dropped. He was notably happier. So really things are pretty well. I mean, there's really the only issue left now is that, we want him to pay for some of his extraneous expenses, his spending money. So he's working as a waiter at night, and he's having a lot of the same problems on the waitering job that he sort of was having in school, where he's having a hard time getting the orders mixed up, and I'm kind of worried he's either going to quit or lose the job. And so there's something about the end of the day that's causing him trouble. And so that's sort of my question to you guys now is, how do we think about this? He's doing better sort of during school hours, but the evening he's sort of starting to kind of unwind a little bit.
Yeah, well, perhaps we should remind ourselves that if ADHD is a neuropsychiatric condition, it can't possibly be a 9-to-5 condition. Or
I
8 to
don't
4.
think there are no 9-to-5
There are no 9-to-5 conditions. But the problem has been that's how we got trained.
Yeah.
And by we, I mean the following three groups of people. Clinicians, we focus just too much on school. 2, parents. They thought that's all the clinician can give. And here's the third one, the patient themselves. They bought what we were trying to sell them, even though there's a problem in the story. It's a continuous condition, and Matt's story is illustrating that if you don't think about it, there are problems. So check this out. Check this clock out. And as you can perhaps see here, there's an interesting twist here. It's not a 12-hour clock. It's a 24-hour clock for all of us. But if you have adult ADHD, this clock is chasing after you. So they have trouble with sleep. They have trouble being organized in the morning, as you were talking about, Vlad. That organizational difficulty sometimes responds very well to medications. But once the medications run out, now, if you don't mind, take a look at the right side of this clock. Come 4 o'clock in the afternoon, 5 o'clock, 6 o'clock, 7 o'clock, 8 o'clock, life does not end there. In fact, life often, psychosocial life often begins there. So I think Matt and Matt's parents and Matt's clinicians, all three constituencies, need to remember there is a 24-hour clock that we need to keep in mind. And that, when we take care of adult patients with ADHD, this clock is often what we're not serving their needs well. So we often are not quite as focused on their sleep as we need to be. Onset can sometimes be too quick, too late. Is it even potent enough, effective enough when they are taking the medications? But I want to really focus your attention on 2 things. How about rebound symptoms? The higher you go, the lower you fall. In a few minutes, I'll show you kinetics, molecules and medicines that jump up too quickly are also molecules and medicines that jump down too quickly. And that, with dopamine, norepinephrine agonists, can come with a price tag of afternoon rebound symptoms, which can be inattention, even worse than baseline, irritability, etc. And then what about in the afternoon hours of 5 o'clock, evening hours of 6 o'clock, 7 o'clock, 8 o'clock? Many of these folks are raising children who have ADHD themselves.
Yeah.
So forgetting about this 24-hour clock is a grave mistake. And even though I was trained as a child psychiatrist, I must tell you, this I learned only the hard way through my own patients. It's time for us to recognize this as an issue. So, first of all, I know you're saying Matt's having some challenges in the evening hours, but first thing to remember is this: is Matt really taking his medications? So, Texas Medicaid database, which is quite good, is showing us that even with adults who want to get treated, their memory about taking their medications is spotty, especially if it's twice a day. Then you pretty much can forget it. So we want to make sure that Matt's not having pseudo failure on his medication. Okay. Another one is, let's make sure he's on the right dose of his extended release methylphenidate. And if that doesn't work, guess what? There are many other choices.
Really?
So
Aren't they all pretty much the same?
No, thank God, no. In a few minutes, I can show you the vast differences. So, yeah, so 30 years ago, we had perhaps, 3, 4 options. But now, my firepower in adult ADHD is actually perhaps the largest firepower I have in any condition. And that includes mood disorders, anxiety disorders, etc.
Okay. Firepower meaning selection of agents and number of agents?
Both of them. So we are blessed with more and more non-stimulants, stimulants, but we made real strides in the release mechanisms. And that has allowed us, remember the 24-hour clock?
Yeah.
I mean, what am I going to do with potency if the potency only lasts 3 hours, 4 hours? What to do with that?
Right.
So yes, you're right. We have really found great ways to alter the kinetics of the compounds. So I hope you'll go back to your clinician and with Matt and alert him or her that the 24-hour clock that Matt has, and by the way, Matt's self-esteem, confidence is not just about how well he does in school, it's how well he does outside of school as well.
Absolutely, yeah, sure.
Yeah. So why don't I offer you the options that are available to help our kids, no matter what age they are. Stimulants, it is true we haven't been able to come up with more than 2 in the last 55, 60 years of looking, but we've done really good things with methylphenidate and amphetamines. I'll show that to you in a second. Atomoxetine, I'll give you trade names too because that's often helpful. Strattera, it's available generic as well, is approved for the treatment of adults with ADHD. Does have some challenges in terms of side effects and efficacy, but if done well, can offer round-the-clock coverage. And I must tell you, even though it's approved as a once-a-day medication, I most often use it twice a day. It's approved as both, actually. Alpha agonists, we don't use that much of them in adults, but perhaps we ought to. Guanfacine extended release, clonidine extended release. These are the world's first 2 medications approved not just as solo treatment options for ADHD. By the way, trade names. Guanfacine XR is Intuniv. Clonidine XR is Capvay, Kapvay. Both of them are generics now. You can also use them as augmentation agents. There are several other molecules that are just about at third base and will be approved, I expect, in the next few months. But we often off-label use medications like bupropion, modafinil, tricyclics, etc. In other words, Matt should not be suffering. Matt himself, Matt's parents, and Matt's clinicians should form a nice team in order to address it. It's true that these drugs have different efficacy. That's no question about that. And that's one of the things that we should keep in mind. The most efficacious medications by far are the stimulants. Problem with stimulants is, of course, half-life. That has been a consistent challenge with these medications. They're very much pocket rockets. Mm-hmm. And in order to make them last longer, we have actually worked, oh my Lord, very hard. Look at this one. This is like...
Can we see if people in the back can read that? Everybody in the back, you can see that back there?
yeah, if you can't, well, I'm sorry.
You need to get your glasses adjusted.
No,
obviously.
it's a tough one. So this actually comes from a paper me and a few colleagues wrote recently. We were looking at all the current treatment options available, and I was pretty certain it'll be 100 or 200 reference paper. This was 600, almost 600 references, wow. Because the world has done a lot of work in the world of adult ADHD and pediatric ADHD. But let me give you a couple of key messages here. We'll start with this. Start right over here, if you don't mind. Yeah, that's not a typo. That's 1955. 1955. That's when methylphenidate, the first compound, became available. But do you notice something interesting? Duration of effect, 3 to 5 hours. And I trained, not in 55, I wasn't born then, but I trained somewhere in the late 80s. And we were giving kids methylphenidate 3 to 4 times a day, and we would get mad at the parents for not sticking to that regimen. It's impossible to do it. But I want to really focus on this. Look where we have come. Over time, by just finding pharmacokinetic ways to do it, we have truly extended the efficacious life of same compound. We haven't changed it one bit. All the way to 8, 10, 11, 12 hours. That's good. That's very good. But that's not the only molecule we have, right? Here, let's go with this one. Not a typo, folks. That's 1943. 1943 is when Dysfunction was approved. Now, by the way, Ciba-Geigy, when they approved it for women to take it right before their husbands came home from work. It was for... They did. There are ads that I have on my laptop that really are... Have you spent all day working in the kitchen? Yeah. Have you washed clothes? It's time for you to freshen up. Put on a new outfit and pop this pill so that you're perky for your husband.
Nothing works for marriage like a little bit of meth.
Yeah.
Apparently.
Yeah.
Apparently. So we did go wrong, so to speak. But very quickly, by the late 50s, mid 60s, by that time, its role in ADHD was established. But here, too, I want to alert you. Less than 6 hours duration of action. Look where we are. 10 hours, 12 hours, 13 hours, and we finally have a 16-hour formulation. I can give you trade names, too, if you would like. So here, this one, of course, was Adderall, that mixed amphetamine salts. We had then Adderall XR. We had many other. Liquid formulation has come out. You probably do know that. Dynavel XR. That has an effective half-life of 13 hours. And then finally we have this one. At the moment, the king of the hill. It's right here. This one is called SHP 465. That's the generic name, the research name. The trade name of that is Mydayis. And it's a triple bead formulation, and in a patient, like what you're describing.
Yeah.
I don't know what time Matt gets up, but if he's a college kid, he's getting up early and is rocking and rolling. A 12, 14, 16-hour formulation is good. Only problem is, if you make it longer than that, then you have trouble with sleep. So let me go back. We've made real success. We've made real progress. I want to urge you to be aware of progress we have made with both methylphenidate as well as with the amphetamine medications. But let's not stop there. And I would like to alert you, as well as all clinicians who might just be listening in on this private conversation, that even the non-stimulants, we're making some real progress. It's not just Strattera. There's many other medications. I won't go into the details here. This one, the Sotoline, I expect to be here with us in just a few months. That also would be an...
Isn't it FDA approved right now? Being FDA reviewed?
It is being FDA reviewed, as are a couple of other molecules. Because adult ADHD is maybe 21st century is one of its great challenges. This century is not a century of people making a living with their hands. It's cognition. And you can't do executive functioning well, you are finished, really. All right, so the good news is, as the medications keep getting extended, their abuse potential does appear to fall. So I come from Austin, and we have a real epidemic with short-acting stimulants. I mean, a real epidemic. And the moment you offer these kids or adults an extended release, they want nothing to do with it. They want that immediate release. And that's a red flag and a problem. And we're finding out when they're using it. They're using it, obviously, for studying, but they're using a lot of it on Saturday evenings to make the alcohol not feel so alcoholic. In other words, they want to keep drinking. Yeah, it's becoming a real challenge. So short-actings really are a challenge in more ways than one. This is something else that I and a very good pharmacologist, we wrote about this paper just to see what the abuse potential was. And it's a complex paper, but pretty much the take-home message is shorter the acting the molecule, in other words, the release mechanism, the greater the challenges. So you do have to watch out for that quite a bit. I know people worry a great deal about cardiovascular events with stimulants. I have some really good news. You were talking about the great beauty of how well the Scandinavians do in terms of data keeping. Here's another great gift from them, as well as the American database shows this. If there's no pre-existing challenges with cardiac issues, our stimulants are not associated with the increased risk of any kind of cardiovascular event, any. Now, sure, blood pressure and pulse does go up, but in the majority of patients, not significantly, and obviously monitoring it is required. So I'm hoping Matt's clinician is keeping a tab on the blood pressure and pulse. That's something to do.
Okay. So again, a little bit of time passes. Gentlemen.
Hi, Chuck.
Good to see you.
Hey, how you doing?
I'm okay. So let me give you an update on Matt before we talk turkey on the business stuff. So thank you. Maybe fortunately or unfortunately, you were right. He was missing some doses. It's interesting, you know. He wasn't trying to, but I guess that's part of ADHD, right? He was having some executive troubles in the morning before he took the medicine. So anyway, he really doubled down. We worked on some systems for trying to get him to take it every day. And he clearly noticed he recognized then, and it kind of came more forthcoming about the fact that it was the nights that he missed it altogether that were real problems for him. So things got better, but you know, he was still having some problems all the days, even when he took it. So the psychiatrist switched agents to a longer half-life, and as you were talking about the last time I saw you, it helped. So he's definitely now doing better at work. In fact, you know, it's interesting. He's doing so much better that, and he's gotten so interested in sort of the world of ADHD. It's interesting. You know, he may well turn out going into mental health because of this. And I think he's so impressed by how much better he's doing that he's now kind of trying to figure out, well, is there something beyond the symptoms? Is there something else I can do to sort of get my life up to a higher level? You know, and so I've been, you know, when I see him, I've been talking to him about this because one thing I've noticed about him is that, you know, he's not depressed anymore, and I wouldn't say he's clinically anxious, but he's got a hard time handling stress. You know, it just more than you know, you can just see it, and he's overly hard on himself. You know, he tends to blame himself for stuff, and he tends to feel shame really easily. So I told him, I told him I was going to see you and ask you, you know, what do we know about ways? You know, now that we seem to have optimized his medication regimen, you know, are there ways that we can, you know, kind of really, you know, take it all the way to the top?
Yeah. So remember when we last met, Vlad had talked to you about diagnostic criteria?
Yeah, absolutely.
Do you remember that? Okay. So be careful with a following point. Diagnostic and statistical manual is to help us get to the right diagnosis. It's really not to define the disorder.
Interesting.
Yeah. So, for example, if you have a patient with a cough that comes from, let's say, a bacteria or from a cancer, you do have to kind of look for commonalities, a cough, but then you kind of split into individuality as to the
around
condition.
the mechanism, sure.
Correct. I think with ADHD, it's really important we not let DSM tell us what the disorder is. Really important. It's sure you need all those symptoms, but watch this now. The reason why I'm making such a big deal about it is one of the conditions with the highest rates of low self-esteem and poor mental wellness is actually ADHD. It's never described in DSM because that's not a differentiating symptom.
Yeah.
But the reality is people with ADHD, because of the constant reminders by life
Yeah.
that they are not living up to their expectations, they are not meeting their obligations, they themselves catch themselves being forgetful, mislaying things, forgetting appointments, it actually does appear they develop a whole set of maladaptive schemata.
And, are you saying also that folks who have ADHD have different coping with stress? Because interestingly enough, that's when things came unraveled in Matt's life.
Absolutely. Well, you could see that the stress.
You're so right. And their coping strategies may have started out trying to aim them in the right direction, but very often they give up on it because they don't see it as efficacious. So instead of asking dad for help or teacher for help, the opposite could become
They just beat up on themselves.
They beat up on themselves, and then they often shut down the very venues that could help them. So if you ask them to get an organizer, who the hell are you to tell me about an organizer? That's a real problem. But I also need to point out that often ADHD individuals are rough, tough on the outside, but as you look at it, their ability to handle stress and their well-being is considerably impaired.
Because I'd read somewhere, because I've been trying to read up on this, that sometimes this is, if somebody's really hyper, that this can be a differentiator with bipolar disorder, right? That if people are manic, they tend to have a sort of overinflated sort of sense of self, whereas
when
ADHD,
they are manic. Now, when they're in a mixed episode, that might not be the case, etc.
Right.
So this act of creating a differential diagnosis is actually important. And Vlad walked you through it when initially he talked about, even though inattention can be a common symptom, it's important to break it apart. Mm-hmm. And as we say in Texas, a dog can have ticks and fleas. Yeah. So you really can have ADHD and bipolar disorder. It's a really good idea to never try and force the patient's presentation into a single.
Box.
Yeah. If it doesn't fit, you must acquit.
Got it.
Yeah, you have to do that. Cognitive behavior therapy is grossly underutilized in these patients, and that's a mistake. Our meds are highly efficacious, that's true, but this is a lifelong condition. It really is. Matt's now, I think you said about 19 or 20.
Yeah, 20.
I'm afraid the odds are when he turns 80, 90 years old, he's going to still have the symptomatology of it. Hopefully he won't have impairment. But as Vlad said, because the coping skills can be a challenge, self-esteem can be an issue, well-being can be impacted, to not offer them CBT just seems like an error. The other thing that I'm really appreciating recently is offering coaching referrals to my patients. So depending on what location you're in, very likely you have access to high quality
coaching.
Yeah. So often they are therapists,
Okay.
psychologists, sometimes they're not. You really do want to get a word of mouth referral, but coaching focuses on non-CBT skills, has to do a great deal with organization, stress management, calendar management, time management, prioritization. And my gosh, those sound like silly things, but even if you make a bit of an impact in them, the returns are high and immediate. So do consider that. Yeah.
Okay, well, cool.
Helping someone with ADHD can be very gratifying when you offer them a medication. Stimulants have helped them dramatically. The thing to remember is you just won the sprint, but life is a marathon.
Yeah.
Don't forget sprint and marathon both need to be taken care of.
Okay, well, thank you. We'll take a couple of questions. I'll because you guys are the experts. Let me read the questions to y'all.
But this is so gratifying. I'm so glad you're
really
willing
good.
to take this on. Helping someone with adult ADHD is one of the most gratifying things I get to do all day long. So glad you join us in that passion.
Here is a really good question. Gentlemen, should we give stimulants to adults with ADHD who are not working or going to school?
Given that they have the rest of their life, as in...
Yeah, exactly. You have to ask, well, what are they doing if they're not going to...
Well, yeah, hopefully they're trying to get a job, right?
Yeah.
Hopefully they have relationships. It is, yes, it's particularly important at work.
Yes.
But ADHD, by definition, affects every aspect of one's life. So if one is in school, they're trying to
Or raising a family,
raising a
driving.
family.
Well, even back in the old days, they wanted to give the wives stimulants, right, for the wrong thing. But yes, I mean, that's the point is, unless you're going to lay in bed all day long and do
Right.
nothing,
Yeah.
you want to have your executive function. Okay, but there's another couple of good questions here that are linked. Okay, in adult patient with ADHD and bad anxiety, stimulants worsen or help anxiety symptoms, and will they worsen or what will they do with mania, hypomania? So
It's
Let's break it down.
why don't you take anxiety? I'll take mania.
Okay. Okay. Deal. Quickly. You would be surprised how often the anxiety is secondary to their ADHD. You'd be shocked and surprised. At least I have been. So I used to unitarily think, anxiety, give stimulants, you're worsening them. No. And based on differential diagnosis, ADHD is the primary driver. I've been gratified beyond words at how the anxiety symptoms can respond to stimulants. Having said that, if they have a secondary condition of an anxiety disorder, treating both has been also equally gratifying.
When it comes to mania, I'm categorically against monotherapy with stimulants in mania. On the other hand, if one does have a foundational mood stabilizer, mood is stable, so there are no mood symptoms that interfere with functioning, but the person still has prominent ADHD symptoms, very carefully introducing stimulants and carefully titrating them up is appropriate. There are studies supporting that practice. Again, slow titration is a key factor. Why do we need them? Because, as Rakesh has pointed out, ADHD symptoms in bipolar not only have to do with level of wellness, but they also have to do with coping with stress. And if they're having problems in multiple areas in their life, it increases stress. Stress is one of the main triggers for changes in mood in bipolar disorder. Again, very important, because if we are too aggressive with titration of stimulants, we can push them a little bit into hypomania and mania.
although I think there's less data that they're a risk than antidepressants, right? I think there's more of a risk from antidepressants than psychostimulants, aren't there?
You know, even antidepressant with good foundational mood stabilizer risk is sometimes overstated.
All right, general comment. These are great questions. In fact, I'm sitting here thinking at Psych Congress, we should think about doing a session where we these are really good questions, folks. Thank you. I'm sorry.
Come catch us during the
we
breaks.
can't get to all of them. So, all right. Well, thank you very much. And
Thank you.
Now I think.